Welcome to the Global Robotic Assisted Surgery podcast. I'm Professor Hitendra Patel, and I'm welcoming you to the multiple episodes we have over the coming weeks and months. I hope you enjoy. Welcome to the Global Robotic Assisted Surgery podcast. In our next episode, we are very fortunate to have a global star in the field of pediatric urological surgery, and in particular robotics. Dr. Sujit Chowdhary, thank you so much for joining us today.
Thank you. It's my privilege.
We know a lot. I know a lot about you, but our audience would like to know something about you. So we'd love to hear a little bit about the journey of your rise in the field of pediatric urology, with an emphasis on the robotics and laparoscopic side of that work that you've done in the past and are currently doing.
Right. So back in 1994, I finished the formal training in the field of pediatric surgery that the best Indian institutions could provide. And after finishing that, I was fortunate to go and get a chance to work in Birmingham Children's, where I was working with the then president of the BAPS. And that is where the interest in urology arose. And that was a very turning point in my career and also in the field of pediatric urology, because that was the time when all the minimally invasive surgical approaches were descending down into the field of pediatrics from the adult world. And I was once again then lucky to get a faculty position in one of the busiest teaching hospitals in Chandigarh, where I came back to be on the faculty. And after working for a couple of years, I had the chance to go back to Great Ormond Street again to be the fellow to a legend in our field, Professor Philip Ransley. And that is where one got the chance to develop and acquire knowledge and skills in the core field of pediatric urology. And I had the chance to continue my journey in Apollo Hospital thereafter, with a short stint with Professor C.K. Young to acquire higher surgical training in minimally invasive approach to surgery. The robotics was then, as you know, in its infancy, and we had the ESOP robot in Hong Kong in 2001, 2, 3. And then there was a window of a decade nearly, because we in India did not have the Da Vinci and we were late to acquire it. But in our hospital, it came only in 2012, 2013, by which we had a very robust pediatric urology program set up. And laparoscopic work was already going on. So when the robot arrived in 2013, we had the chance to make a lane shift from open and laparoscopic work into robotic. And nearly a decade now with robotic reconstructions for pediatric urology. And it's been a terrific journey.
Wow. Well, thank you for that synopsis of your journey. You're a very humble man saying it was luck. I'm sure it wasn't luck. A bit of luck, maybe 5%, but let's say 95% talent. Yeah. So, obviously you worked with people like Philip Ransley, who I was very fortunate to have met before he retired, because I worked in the same group as him in the UCL group. But you've been in some amazing places around the world, and you've worked in amazing institutions. Chandigarh, of course, is obviously well known also. Now, just tell me a little bit, because of the access to technology, cost being prohibitive in some senses in some places, do you think that's why it was the robotics sort of systems were slow to come to India, or do you think there were other factors? What do you think?
I think the sudden rise and spread of robotic surgery in India is the solo credit of Vattikuti Foundation and Mahendra Bhandari's push with Professor Mani Menon and Mahendra Bhandari pushing the robotic surgery into India via Vattikuti Foundation and helping it grow in its journey in the first 5-7 years. We had a very exciting start with all-round encouragement for robotic surgery. And of course, I was lucky to be in a hospital group like Apollo, who had the wisdom to subsidize pediatric work with the huge volume of adult work they have. And they took a charitable view to the rise of pediatric robotic surgery, without which I'm sure that at least the pediatric robotic work wouldn't have taken off in a country like India. So full credit to the financial masters and the promoters of Apollo Group in that. But yes, I mean, now there are many public institutions in the country where the robotic surgery is available. And if a child needs it done, I think there are sponsors available for that.
Okay.
It's not out of reach.
Thank you. Let's just jump into pediatric robotics then, because there's our positive messages and there are not so positive things. So it's early. Would you say you're still in the early stages? Because apart from urology, pediatric urology, which obviously you're an expert in, it's not really. Is it rolling out into other areas now in your experience?
So, what I can say is that there's been almost complete transition of pediatric urology from open to minimally invasive in my practice, at least, in any baby who's more than 3 months. The second comment that you make about the deeper penetration of robotics in other fields of surgery in children, it is happening. I think the application of robotics to GI surgery and thoracic surgery within the pediatric field is also happening, but not in the same volume and speed as urology, because the application is much more in urology.
So do you think the reason there's not this adoption, what are the potential reasons why? I mean, we have adult urologists like me doing robotics, so therefore you might think, well, maybe it distilled its way down to pediatrics, or up, I should say, sorry. But why do you think it's not being adopted with the other areas, the other specialties?
I think that we have to accept with great humility that the laparoscopic skill of general surgeons was far superior to that of the urologists 20 years ago.
Okay.
And I dared to say that to Mani Menon in one of the meetings, and he kind of accepted it. So,
did he? He accepted that?
Yeah.
Oh, wow.
Yeah.
Okay.
Grudgingly.
I was going to say. Okay.
Yeah. So, the GI surgeons are essentially an extension of the general surgeons, and many of them have got very high level of laparoscopic skills and find robotics maybe an unnecessary investment.
Yeah.
The urologists, on the other hand, did not have the benefit of the ubiquitous gallbladder and appendix during their training years. And so maybe the robot came in as a gift from God for the urologist to swiftly move into the minimally invasive field and be able to duplicate very complex laparoscopic reconstructions by the minimally invasive route with a very short learning curve. And the progress just went on at rocket speed. Whereas the general surgeon is still stuck in his igloo with his maybe higher level of laparoscopic skill, but is not able to come out of that resistance that, let's switch on to robotics.
Yeah.
I don't think it's just the cost. It's much more than that. It's the mind frame of the surgeon.
Yeah. Let's agree that there's a human factor to that, right?
Yes.
But in terms of actual patient outcomes, in the child, in the pediatric case, would you say there's a huge difference in outcome between open pyeloplasty and robotic pyeloplasty?
So what I would say is that, the difference is not so much in the results in the highly skilled hands, but the difference will be more demonstrable in terms of the fatigue of the surgeon, in terms of the long-term outcomes, in terms of the operating time spent, in terms of the complications. What is happening currently is that whatever is published, the laparoscopic pyeloplasty is being done by surgeons who are almost at the end of their training or acquisition of skill. So it's not easy to demonstrate the benefit of robotic surgery versus laparoscopic surgery because of the way surgery has evolved. And the parameters tested have always excluded the surgeon's fatigue in the time of surgery.
Yeah.
And that is one aspect which has never been studied. Second, the aspect of complications can't be demonstrated unless the numbers are huge. If you look at any pediatric series, they are comparing 30 cases versus 30 cases. Even that is not prospectively studied. Those are retrospective studies. So unless you're able to compare over 100, 200, 300 cases side by side, prospectively entered, multi-center, you're never going to get the real truth. But if you asked me from my experience, there has to be a huge difference just by standard logic. Wherever there is suturing involved in fine areas, there is no comparison between laparoscopic suturing and robotic suturing.
That's an interesting comment. I read a few years ago when the big bun fight happened between open, lap, and robotics, and we were in the middle of all of these sort of discussions. One of the funniest comments I ever heard was the robot is a $1 million sewing machine, and I know it was done tongue in cheek. It was just a light-hearted comment, but it does have its merits, as you just said. So back to some of the things you just said a second ago, in terms of surgeon factors, in terms of fatigue, in terms of, let's call it complications of the surgeon. I like that sort of area, because I've helped lots of people, and we've looked at this, and I beg to say, we've even studied it. And so with robotics versus open surgery, there are obvious differences, aren't there? So with pediatric cases, you still have a giant machine. So can you just reassure our listeners about the port sizes and the fact that even though, why don't you tell me a little bit about how you look after the small infant when you're doing robotic surgery over 3 months? Just for this.
So although in America, there are surgeons who are doing portoenterostomies in smaller babies robotic, but I have found that whenever the baby's weight is less than, say, 5 kilos, or the baby is less than 3 months, you can do the operation. It's not impossible. But I think it's a strain on the patient, and it gets a little tight in terms of space. But anything more than 6 kilos, it's quite okay for anybody who's regularly operating on babies. The space is not too much of a problem.
Okay.
The port size is slightly big, and it's a giant machine crowding the patient from all sides. And in the early years, it looks as if it's all unnecessary. Yeah. But as you get used to And then you realize the benefit of using this machine, this technology, for being able to complete much more complex operations like ileocystoplasties, tumor surgeries, partial nephrectomies, which you would otherwise be doing open, or you'd be doing laparoscopic, but taking much, much longer time. Then you don't mind all these initial disadvantages. And bearing the cost factor, if you are not fortunate to be in institutions which is not doing 1,000 cases a year, then it's not probably economically easy to justify. So as far as the capital cost of the equipment, $1 million or whatever it is, that is an initial investment that the institution has to have the muscle to invest. And if the institution is able to do 1,000 cases a year, it quickly evens out. And out of those 1,000, the pediatric cases are going to be not more than 70 to 100, which is a very small number. And, I think that this disadvantage of a large size machine, arms, equipment size, port size, etc., is largely an obstacle which is in the mind for the first few cases. Once you cross 25 cases and you have become convenient with that, you've got used to it, you have a team which works together in and out with a patient, the same team, then all this doesn't take much time.
Yeah.
So it's the first 25 cases that have to be rolled out, I think. After that, it's all simple and straightforward.
So that learning curve's a nice little caveat to move on to then. Obviously, in India, you have very high volume centers because that's India. And for example, in the UK, when you worked here, Great Ormond Street, they were pretty high volume for the UK, but you must have been smiling compared to what you do in India. I mean, it's literally low volume, high volume. So do you think you think they should have less centers having higher volume? For example, let's take the UK, then it's not controversial in this conversation. If we take the UK, instead of having every hospital having a robot, what would you think about having, say, 4 pediatric centers doing all of the robotic work? Would that work, do you think?
Absolutely. I think unless you concentrate work in numbered centers, you're never going to be build it. So I 100% agree that, like pediatric surgery, in the 1980s, there were hardly 4 or 5 or 6 teaching centers in pediatric surgery in the United Kingdom.
Yeah.
And these were centers of excellence. And the masters in these centers were world famous and respected all over the world. Now, by spreading that work over 35 centers or 40 centers, all you have done is that, okay, the same work is being done in many places, but you have lost the position of academic recognition, academic positioning, and I think robotics is another such opportunity. If you started in 1 or 2 or 3 or 4 centers for the entire nation, then there is enough workload for academic output from this field to prove the points we are talking about.
So let me ask you something slightly around that subject, because I'm interested in your view, because you have a very broad view on many topics, as we're finding out today. If you had, let's say, a master surgeon in 1 or 2 centers, people that you and I would consider, elite surgeons, like yourself, then you have a group of people, because the volume's too high, you can't do more than 1,000 surgeries a year. So you have 1,000 surgeries done by the master surgeon. Would you think, or do you think that the technology like the robotic systems, there are several, as you know, in the world, do you think those robotic systems make the average outcome surgeon, let's call it above average outcome surgeon? Do you think that's true?
I think what is true is that there is access to every surgeon to do laparoscopic work. A, and B, in the world today, every pediatric surgeon is going to try to do every operation laparoscopic. And in that, he is going to produce failures. So an average surgeon has the potential to remain average because of the complexity of completing an operation by the laparoscopic route. We all know is not easy for reconstructive surgery. Whereas, if the same surgeon had the benefit of robotic surgery, he may have the potential of being converted from an above average to an above average surgeon. So the final beneficiary is the patient.
Yeah. Although we'd argue that the patient is the most important outcome, patient-centric process, right? Oh, that's certainly how I think about it. And if we're trying to democratize surgery around the world, technology can help that, can't it? So I guess we're agreeing. I've known in my world of adult urology and robotics, I noticed that actually very good surgeons in lap and open surgery, some of them just could not work the robot as well. So do you think robotics is for everyone, or do you think people, how do you think we should go about making it easier for us to pick who should be doing it, who shouldn't be doing it?
I think that, certainly people who are on the verge of retirement, they should not then change their track in the last 1 or 2 years or 3 years or even 5 years just to grab hold of the technology or trying to prevent it to filter down to the younger generation.
Yeah.
Number one. Number two, I certainly don't think that a trainee should think that he can jump from the open surgery to robotic surgery straight and does not need to gather years of experience before imagining that he can do it all robotic, because you can make terrible complications which you will have to fix. So certainly, as you said, that from a national perspective, whether it's in the private multi-hospital chain or whether it is in a national public health system, institutions have to be identified. Then within the institution, centers have to be identified. And then surgeons have to be identified who have got a few years post-training completion. And they then, I'm sure, will rise to be the top robotic surgeons for their field, following the same organ-based specialization as has happened in the adult world.
Yeah. Excellent. Thank you. That's a great overview. Now, can I just change the subject slightly? People are really interested in what makes a person at your level, so, senior elite surgeon like you, what is it? What do you do when you're not working? How do you enjoy your days? Are you in charitable work? What are the other things that make you tick, that give you that make you who you are?
Yes, we have the opportunity to treat free patients, which form about 20% of our work within our hospital, which is a private hospital A.
Wow, amazing.
And B, I work in a hospital which is about an hour's drive from here, which is completely the patient doesn't pay any fee there. There is no minimally invasive surgery. There's only open surgery there. And, but it's all life-saving, and patients benefit from surgery in such interventions anyway. I also support a small charity which does surgery in a very remote part of the country.
Yeah.
Apart from this, there is a little bit of time spending with some organization, particularly the Ramakrishna Mission activity, which you may be familiar with.
Yes, I am. Very good.
Doing some very stellar work in the field of education.
Yep, amazing. But Dr. Sujit, how do you look after yourself? What do you do to take care of yourself?
Oh, that is confined to at least 1 hour of brisk walking every morning.
Okay.
And the occasional sporting activity. Nothing much more than that. I am not a great gym person or into heavy exercises.
Well,
the occasional trekking holidays are there.
Okay.
That's it.
Well, you know what? If you don't mind me saying so, you are a shining light of excellence. You're a man of great humility, and all I've heard is very humble and highly professional responses from you today. And I'm sure our viewers and listeners will enjoy hearing more from you. But Dr. Sujit Chowdhary, it was an absolute pleasure. It was an honor also to talk to you. And I hope we'll speak to you again. Thank you so much.
Thank you, Professor Patel, for this opportunity, and it was lovely meeting you.
Yeah, thank you. And that's it from today's Global Robotic Assisted Surgery podcast. I hope you enjoyed it. Dr. Sujit Chowdhary on Pediatric Robotic Urology. Thank you.